again, I'm excited as we continue our PowerTalk podcast to have Dr. Ichechim White here with me. Please introduce yourself. Tell us a little bit about what you do, what you're into, just who you are. It'll be great.
Lovely. So I'm a GP, or I work as a GP in South London, and I also help run a adolescent clinic one day a week as well, one afternoon in South London as well. Yeah.
And we've done some training together. You've done some work for us for Power to Fight. And one of the things, and I think we met on social media, particularly at a time off the back of kind of George Floyd and stuff, and which was really interesting because obviously it was around COVID times as well. So I think maybe everyone's social media uptake went up. But I was always fascinated. And one of the things about Power to Fight is that we try and look at this issue around youth violence from multiple perspectives and try and give a voice to spaces which you wouldn't normally see speaking into this conversation. So I've always been thinking, okay, what is a GP perspective on this issue? Because they will see young people, they will see families. And then we'll get into a little bit later some of the training stuff that we've done. But I suppose the first thing I just want to talk to you about is we have seen, tragically, in a London context, 30 young people lose their lives in 2021. Just from your perspective, what do you see day to day with the young people, families who are going through this type of issues with kind of violence affecting young people, just from your perspective? Because people will not know, people will not see half the things that you've seen or the experiences you've had. Just give us a bit of an idea of what you see.
Yeah, so sometimes it's what you don't see. Yes. So the young person who is booked to see you but doesn't come, or turns up late, or things look chaotic with there's lack of using the medicines that they might need to be using for a long-term medical problem, or they're within a family that has significant needs, and therefore it can be a real barrier to access care or the support that's needed. Because actually, if you are struggling with unemployment or hunger, your medical needs might end up dropping to the bottom of the pile. So what we see as GPs often is just the need, and we can see the complexity of the family relationships and dynamics if there is a family member who is struggling with their mental health as a parent, and then the knock-on impact that has, or there's substance misuse because of mood and because of all the other things that are going on for that adult, that then knock-on effects that has on a young person who is maybe trying to take on a carer role or multiple other things. So, yeah, I think we are really privileged to be privy to the complexity of people's relationships, the networks that they live in. And sometimes it's just a snapshot, but often over time, it's much more than that. And there's kind of a wealth of information that we carry as GPs as well.
Yeah. And we talk about frontline practitioners. I mean, you are really at the front line, and the complexities that you've just described, I don't think the average person would really think about. What do you do with the things that you see and don't see? I mean, I can imagine that you would see some of the things you just mentioned, whether it's the substance misuse or the adverse childhood experiences. And are you a bit like a police officer investigating, and you start connecting the dots and you start trying to map that person's life? And do you often see the link to violence and which affects young people, or does that actually come a little bit later down the line, or can you clock this stuff kind of quickly?
I think sometimes there are big gaps where young people aren't accessing us directly. And maybe there's all that's on their notes is hay fever from, for many years or nothing much, until you receive a discharge summary from the hospital that they've had an instrument, that has caused injury, or that they've, been discharged because they've got some other injury, and you don't necessarily know the detail of that or understand exactly why. I think that's an opportunity which is being understood in like the hospital space of like let's intervene now. This is a teachable moment. Let's have youth workers in A&E doing that work. But it also is helpful for us to think in primary care and in general practice. Yeah. Okay, well, also is this a moment where we can reach out, where we can develop a link, where we can understand what's happening for that young person? And then more so, which sits really well as GPs, we're well suited to thinking about health promotion and thinking about a young person's mental health. And we know that that's a really significant part of the health burden now, and it emerges really early.
Yes.
So that's maybe what we see more of or identify more of.
So give us some typical examples of when young people come in. What are the signs that you see where you're thinking, oh, I'm a bit concerned, type of stuff?
So it might be actually that it takes almost the whole consultation to get to what they're really coming in about. So that can be difficult if you're pushed for time and you don't have much resource in terms of GPs. That quick consultation that seems to be about something benign feels much more comfortable to kind of be like, okay, that's the end of that.
Yeah.
But if you're able to take a holistic approach and there is space, just kind of dropping in that you can come back for these issues, or if you're feeling low, or you're struggling with your eating, or there might be a myriad of things that anxiety kind of seems to be appearing, health anxiety, booking multiple appointments, for example, about something, that you follow up on that you make space and encourage seeing the same GP. And yeah, so those sorts of things are what we might pick up on. So mood disturbance or difficulties with eating, disordered eating. It might be that there's kind of worries around housing or something else that seems like a tangential social issue, but you might be able to unpick that, see what's going on.
No, that's really helpful. And one of the things so I used to work for a mental health charity, and even some of the therapeutic work that we now do, the things which often come up is the over-reliance on substances. Definitely when I was working for a mental health charity back in 2010, 2011, skunk played a massive role in psychosis and bipolar and stuff like that. Is that something which you would have seen an increase use of with young people coming into your surgery? Like, I'm not even sure how you pick that up, but because it's unlikely that they'll come and say, hi, are you skunk, and help. It's unlikely. But obviously with the demand and supply of drugs, or supply and demand in the cities and stuff, and we know that how the drug market works, do you often see the effect and the impact of young people coming in? Is this a big thing, or are we overplaying it? Is it not as a big issue as we believe? Or just from a GP perspective, just kind of interested.
Yeah, I think it is something that kind of interlinks with mood.
Right.
So you're able to unpack that maybe alongside with other risk-related behaviour, especially in that adolescent period, if you're actively looking for it. So if you're exploring somebody's low mood and exploring their sleep and exploring their use of something to help with the way they're feeling, whether that's alcohol or other substances like skunk, in a non-judgmental way, then often that will actually come out, because a young person may not have connected the dots, may see it as a plant substance that's not actually a drug. It might be very normalized in their environment. So just identifying it as a linked, potentially this is affecting your sleep architecture, this is affecting your mood, this is making you feel more paranoid, and there is support available for you, it can be a really powerful thing. And we definitely do, I think we do see that. Whether there are young people who feel that they can come into that space and talk about it is another question. And also if it feels like that's what then the consultation becomes about, obviously you're going to shy away from wanting to talk about it if you've come because you've stuck yourself up to tell the doctor that actually you're really suicidal or you're really low.
Yeah, that's a really interesting point. And how about from a sexual health perspective as well? Because again, I've heard stories of young people visiting doctors or GPs numerous times, but not really having the language or the courage to really talk about STIs and all this type of stuff. And how I mean, I'd find that very difficult conversation to engage with. How do you manage that? Is that something you see it regularly? How do you talk through with a young person about particular tests and that type of stuff?
I think actually young people are quite good at asking for that, and they quite like, in my experience, coming to the GP, not just the sexual health clinic. So it's interesting because we'll often signpost young people to sexual health clinics specifically. They don't want to necessarily go to a sexual health clinic often. They might prefer to see their GP and talk about what it is that they're worried about. So I feel like that they access that quite well. And are quite good at asking about that. And again, you can follow that on if somebody's had an unwanted experience where they might fall pregnant. That's another opportunity to talk through that. So it's an opportunistic thing, but So
one of the things I would say, and it sounds like that term that we often use is that cultural sensitivity or cultural competency. And it sounds like you are a very culturally sensitive GP, understands the community, is culturally aware. And I suppose one of the things we often see is that isn't the case for all professionals. And you've been part of some of the training that we've done to try and really increase the cultural sensitivity and awareness for NHS staff, GPs, doctors, surgeons, all that type of stuff. And it's very similar to teaching, actually. I suppose my argument has always been we can't just rely on teaching or teachers just knowing their particular subject, particularly if you're coming from out of inner city areas. So I'm aware of the limitations in the cultural awareness of teachers. When it comes to GPs, is there an emphasis on the cultures which you are going in to serve, and how do you prepare for that? Obviously people listening and watching this have no idea. I mean, how did you become so culturally sensitive and aware? But is that what is missing? What is there? I suppose I'm
just intrigued. I think there are people doing this excellently, and I think when we talk about cultural sensitivity, there's in the wake of everything that has happened over the last 2 years with COVID, and also an unpacking of Black Lives Matter, and people thinking, oh, this isn't just about somebody far off, and it's become very clearly close, and people have felt released to be able to talk about their experiences. It's now become much more of a specific feature. So safeguarding training includes cultural competency as part of it. There are courses and specific courses around this now. I think it feels to me like that has increased in the last few years. But before that, obviously working in an area, you do think about the nuances of the different communities that exist there. You become attuned to some of those nuances. And I have colleagues who have been working for much longer than me who have grown with that. And it's very much embedded in their understanding that actually that there might be some things that this just brings an affront. This just brings a barrier if I talk about it in a certain way. Or I need to really think about, with this diabetic person, Ramadan, and how that's going to impact them. Or, there's these kind of nuances that we kind of become aware of. But I think to ever think that I am competent or that I know it all would be the opposite to cultural kind of competency.
Well, this is a very interesting point because, as you know, we put out our TIP report, our therapeutic intervention for peace report, looking at therapy in the context of violence affecting young people, and we use the term cultural competency, effectively saying, you know, yes, there needs to be more representation, black and brown representation, but not just that. If you're white and you're in this space, are you culturally competent? And then as time's gone on, we've changed our language because, as you've just said there, like competency effectively means mastery, and therefore, can you really master culture? Like culture is fluid, whereas the research we've done, like with humility, cultural humility or cultural sensitivity, takes more of a posture of learning, and ongoing learning, and acknowledging that culture is intersectional, culture is fluid, you know. And so I think it's really interesting that I don't think you can ever say, I've mastered South East London culture, or I've mastered Manchester culture, whatever like that. So that ongoing posture of learning is good. But I also appreciate maybe my expectations on professionals like yourself, be culturally sensitive. Like the work you guys have had to do, particularly in COVID, it's probably stuff you've never experienced in your life. How have you managed that? What are some of the pressures which GPs have been under? Because I think it's important for people to see the complete 360 of what you guys are doing and have realistic expectations. What has it been like for over the last 2 years for you?
Wow. What a lovely
we didn't
question.
plan this question,
no,
did we?
I think it's really topical. There's obviously quite a lot of media discussion around this, and it has felt at times like general practice has been treated as a scapegoat in the real challenges that everyone's encountered. And there were just not enough of us. We know that. There were promises for sort of 5,000, 6,000 more GPs, and there were a deficit of almost 2,000. So full-time equivalent GPs. So I think actually we're working harder than we've ever been working to really give as best patient care as we can. And it's really difficult because I can't speak for every GP surgery, but I do know that my experience is the experience of many, that we really just work, you know, we see the majority of patients who have COVID. We see the kind of challenge it is for people to be taking telephone consultations as the priority, but that is shifting back to face-to-face. And actually we've seen more people than ever before the pandemic, which again, that's not something that people are often aware of. So it just is really fascinating. I think general practice is incredible because people are so dynamic within, you know, you say, okay, you've got to be remote. You need to make sure people are safe, and you need to switch all your processes to enable that. And now you need to see people face to face. And so you need to switch all your processes, and nothing has remained the same. So every day is that sort of cognitive, like, right, how do I do that? How do I get my patient to have that process done or that thing to happen? Whilst we're waiting for long waiting times in hospital, how do I carry this person who has XYZ problem and isn't going to be seen for maybe a year or longer, and support them through that? So I feel that general practice has done more and been more dynamic and responsive in the last 2 years than ever before, and that the hope is that within that, young people don't get forgotten. And I think that there is an element that seems to be the case, where actually, do young people want to have telemedicine as their first point of call? Do they want to have an e-consult? Some people, it is much more helpful, but that's when you have more autonomy. When you're older, you have more control over your timetable. But actually, when you're 11 to 19, 20, 21, 22, you're really restricted in some ways as to how you can access these services. So being kind of encouraged, I want to see you, let's convert this to a face-to-face, let me be able to see you, is just, I think, life-giving. Being told your problem, we care about it early on because we know about the long-term impacts that, these issues can take hold of, they take root in adolescence, but we could do something about them then, rather than waiting for them to be dealt with much later. It's particularly around mental health. We know that 50% of all mental health disorders arise before the age of 15. So this is...
Wow, I didn't know that.
Right where we need to be working. It's why we talk about the teachable moment. It's why we're so interested, and it's why it's so related to public health approaches to youth violence, because actually what is going on for this young person now?
And it's really interesting you say that, because I think what we've definitely seen is that COVID has amplified some of these things. I mean, even with my own children or children that I know, I'm waiting to kind of see what's been the impact of COVID, because there has to be. And maybe we won't know for a few years, but I think we can't and we shouldn't underestimate that. One of the things a friend of mine is a filmmaker, and he did a documentary on his younger brother who unfortunately was stabbed. He survived. But there's this really interesting moment in the film where he recollects when he went into A&E. And he was the victim, but the staff said, you really need to stop carrying knives. And his response to the camera was very much, I never said that I was carrying knives. They've made an assumption, and that accusation cut deeper than any knife wound. This is his words. So there was something which obviously came off the back of that, which was like, well, gosh, there is generalizations, stereotypes, biases towards young Black youth in the medical profession. What's your view on that, and how do we change perspectives, biases? Do you see that playing out? So that's one question. And then the second follow-up question is just, even in your own experience as a Black female professional, just what have been some of the challenges? Has there been any challenges to get to the point where you're at, and what have you seen in your context? I suppose there's two questions in that.
Yeah. I was thinking about this, and just the fact that we talk about youth violence, don't we? And I think when that's brought up, we're thinking about the individual. We're thinking about it on that micro level. And yet I'm just convinced that, there's so much that's systemic violence, that's oppression, that's going on.
Structural.
Yeah, structural. Yeah. And that we have such a gift, being medics, being doctors, being nurses, being physios, to help support and end that by the way we see that young person. Yeah. Because actually, if it is there are people who speak so much more eloquently about this, but I was just thinking about Ibrahim Kendi in the US, and he gives an analogy of like sort of racism being this like cloud, like that's raining down on everybody, and that everybody's experiencing that rain. But it feels like some people have got a waterproof jacket, and some people have got an umbrella, and some people are completely covered by it. And that's your privilege, isn't it?
Yes.
And so if I am in a position of privilege, I have an opportunity to give some of that power over and say, who is this young person actually? Let's learn them. Yes. Let's find out what their situation is, and see them not through the lens of a Black or white or just a young person who has a need, who is vulnerable potentially. Where my training comes in is to identify the need, not to put them in a box or to label them, but to say, okay, well, what do you need, and how can I support that need? And so if I come with that posture, that is cultural humility, isn't it? Or the start of it. How can I understand you? is the compassionate response towards this situation.
Yes.
I'm equipped with knowledge that maybe actually the adolescent period, your brain is developing differently. So your needs are different. So actually the way I approach you is different, because I recognize from a neurological perspective, you actually need something different to the person who's 35 in front of me.
Wow.
And actually you might, on top of that, have experienced significant trauma from what's just happened. So my trauma-informed approach is to say, well, actually, maybe you haven't turned up to that appointment because of your experience of healthcare settings. Actually, this might be an unsafe place for you.
So it's interesting, because what you're doing is you're using language that I love. So you're talking about not just the micro, but the macro. You're widening the conversation. You're encouraging people to look beyond just that person. You're saying, well, let's look at the context. So much of this would come into maybe even Professor Carleen Furman's work around contextual safeguarding as well, looking beyond just the normal way that we'd look at harm and structural harm and stuff around young people. So I think it's really interesting. Is that something which you always had so coming to your experience in gaining your qualifications, become a GP and stuff? Did you have to fight for that? I feel like I know the answer, but it'd be great to just kind of unpack it a little bit, if you don't mind, because the last thing I want to do is actually potentially re-traumatize you if it's anything like that.
I think it's something I maybe didn't reflect on deeply until actually the events of the last few years, and
interesting.
But I've always been aware of that there is an advantage actually when I'm speaking to certain patients, that they would have a sense of feeling understood even before I've really said anything. That maybe just that barrier is gone, and I can I had to realize that was an advantage that I might have over a colleague potentially, or that there's an opportunity for me to be heard and for me to hear them, because they see me as a sister, as some will call me, or and I don't think that doesn't happen for other doctors, because I think once you become attuned to that, there are other colleagues of mine that I know will be asked, how are your children at the end of the consultation, because they get that that's the context, the culture for that patient. And there's work going on around that now, looking at, okay, well, what is it that a Black person is looking for in their consultation, and what are the barriers to them accessing health that actually exist for every patient. But if you do it right for the person who's most feeling not accessing the care because of the structural systemic impact that racism has, then you'll do it right for everybody. So sometimes the rebuttal to that is, well, this is what every patient needs. And then it's a reminder, but not every patient experiences.
Well, it's equity, isn't it? It's effectively saying that it's not equal. It's how we do, isn't it? In an equity way. And I think that's a really good point. I suppose as we're coming to the end of our time, and as always, I'd love to speak more about this, and we have to get you in for part 2. But I suppose the final question I've got is, we've spoken about cultural sensitivity. We've spoken about, and you've just mentioned post-George Floyd. I think for most people, there's an awakening, whether you're white or Black or brown. I think you can't fail to have questioned where you are on this anti-racist journey. So with that being said, and also the fact that we've had 30 young people in the last year in a London context who've lost their lives, which is the highest since 2008. What needs to happen with your sector for GPs, NHS staff to become more effective in this conversation? I don't know. I mean, it's a massive question. But what would you say from your perspective? What needs to happen? What are the things which, it might be small tweaks, it could be big reform change, I don't know. But from your perspective, how do we become more effective, culturally sensitive in this ongoing conversation of violence which affects young people?
I think it can feel quite remote But actually the work that we're doing is the work. You know, the times that we are identifying the safeguarding need and referring, the times when we're also within that understanding what the strengths are for this young person and their context and contextual safeguarding, and bringing that out and encouraging and kind of rubber stamping the softer things that don't seem so important but actually are, like, who's engaging with you in school? How can I relate to school or advocate for you to make sure you're staying in school? And that we're addressing the mental health needs that might exist there, and thinking about those broadly. So now we have social prescribing in most areas, which
just
is,
break that down.
Which is a way to support the social needs of somebody. So that might be around your finances or your debt if you're an adult. It might be loneliness. It might be that you need help with kind of writing out forms, whatever that might be. But for young people, there's still a gap when it comes to that service. So for those who are commissioners and those who kind of create systems, we need to be thinking about that for young people and building that in so that there are, you know, people who are helping young people to access the things that they might need that don't just sit within health directly. And then, so just continuing to do what we do, recognizing it makes an impact, recognizing that this, you know, if this was 30 asthma deaths in a year, there would be significant assessments and reviews prompted by that.
Yes.
So thinking about it like that.
Because
we don't think it's avoidable. We don't think that we don't think that we can impact it. We don't realize that we can impact it. We don't realize that me, you know, seeing a young person and them knowing that's my doctor. Actually, I'm in foster care. But when I saw the doctor, they were talking to me.
Yes.
So I can call the foster carer and say, I'm having difficulty. I'm in trouble. I'm finding this hard. Can I speak to Dr. White? You know, because they've got that relationship early on, will pay dividends later. And we know that globally. We know that there's this triple dividend effect because you're dealing with a young person, you're dealing with the parent they might become, and you're dealing with the next generation they may bring forth. So it's really crucial. It's at such a precious time. So rather than seeing adolescence as just a quick consultation, a relatively healthy population, which they are, this is a time for health promotion. This is a time for developing and encouraging healthy kind of understanding of their bodies, of their minds, and encouraging them to take good, healthy risks. And so, you know, signposting to social prescribers who might be able to be linked in with a football club or this or that. And then also really encouraging youth advocacy and recognising the role that has. And if there is a youth worker or a youth club, you know, getting connected, finding out what they're doing as a surgery and becoming more a part of that community if you can. And I know that there are so many pressures within general practice that feels like it, and I think that is calling on the powers that be to resource that and to encourage that, and social prescribing is just a small example of that.
Wow. I mean, it's just incredible, just some of the things you just said there. And there's so much of it makes sense, but we don't put it into play. The powers that be don't put it into play. But I do honestly believe the work that you are doing and other GPs are doing is fundamental. Like you say, if you can build those relationships, you can influence the trajectory of those young people and families impacted by violence affecting young people. So I just want to say thank you. We are doing some work together. You've been training some of our people. You were going to continue to do some great stuff because our philosophy is always about how many voices can we get, how many professionals can we impact, which ultimately will impact the lives of the very young people we've been talking about. I want to say thank you. I want to encourage you. I want to say that the work that you're doing is groundbreaking and completely necessary. I wish I had a GP like you when I was a youngster, a teenager. But you know that PowerTalk love you and we appreciate everything you're doing. So thank you so much for your time today. it has been much appreciated.
Thank you for having me. I really feel privileged to be here, so thank you.